Well, hello again, or if you're just joining us, welcome. I'm Grant Gibson, CRDCN Assistant Director of Research and Evaluation, and your MC for the day. I want to thank David, Leighton, and Michael for their panel. Very interesting discussion on the census. We're moving on now to a focus on health data linkages. Following this panel, we're going to move immediately into a 5-minute break to give everyone, especially me, a chance to stretch their legs. So I'm now going to both welcome and pre-thank our next panel. Erin Hetherington is a postdoctoral fellow at McGill University. She's joined by Juliana Wu, Manager of Decision Support in the Corporate Data Request Program at CIHI, the Canadian Institute for Health Information, if you're among the uninitiated. And this session is going to be moderated by Alan Diener, Assistant Director of Strategic Policy Branch at Health Canada. Before they begin, I'd like to remind everyone again, questions should be asked using the Q&A function in Zoom. And we also had a Microsoft Conversations link available. It's unfortunately gone down, and we're going to work to try to get another one going as soon as possible. So if you're having difficulties with that, mea culpa, and I will fix it as soon as I can. And all the recordings are going to be available on our YouTube channel as soon as we can get them posted. So I'll turn it over now to Alan.
Great, thank you, Grant. Pleasure to be here today moderating the session. So good afternoon, welcome to the session on the focus on health data linkages. As Grant noted, I'm Alan Diener. I lead a policy research and data analytics team at Health Canada, where we have a lot of projects that really rely heavily upon both CIHI and StatsCan data. And as already been noted in sessions earlier today, I don't need to tell you the need for really strong analytical work and for strong and good data has really been growing exponentially in recent years. So with that, I'm really very much looking forward to today's session and hearing from Erin and Juliana. So with that, I will turn over the floor to Erin, who is from McGill University, to speak about, I believe, health disparities. But if it's not that, we'll find out very quickly. So over to you, Erin. Thanks.
Thanks, Alan. I actually think that Juliana and I had talked about Juliana going first. So if it's okay, I will pass it over to her.
Great. Thank you, Erin, and thanks, Alan. So I'm going to first share my slides. Hopefully you're seeing this okay. All right. So yeah, I mean, Erin and I, we had decided to kind of tag team on this and would be a very fruitful conversation. Very pleased today to be able to be here from the Canadian Institute for Health Information and share a little bit about our 2 data assets, in particular that are regularly linked and shared with Statistics Canada's data through the research data centers. So very happy to be here today. So what I like to spend a couple minutes speaking to is the DAD, or the Discharge Abstract Database, as well as the NACRS, or the National Ambulatory Care Information System. So I'll share a little bit about the content of those data holdings, what is a coverage, data collection, a mechanism like the data elements that are involved in those data sets, and then I would turn it over to Erin to speak to some real-world experience in using these linked data sets. So first off, I think many of you on the call may be familiar with the Discharge Abstract Database, but essentially it's a very long-standing data holding that is hosted at CIHI to capture all of the hospitalization data across Canada. So as you can imagine, all acute inpatient hospitalization data would be submitted from the hospital directly into CIHI. I'll speak a little bit about the data elements and the types of information captured in each of those records. The data actually dates back to the 1960s, and but typically when we talk about linkage or analytical work, a lot of times it's restricted to the last 10 or 15 years, but it is a long-standing data set. The NACRS, or the National Ambulatory Care Reporting System, is also mostly about hospital data-based data, but largely it's the day surgery data that we have captured across the country, as well as emergency department visit data. The NACRS is a little bit of a relatively newer data holdings, and over the years, we have been trying to grow the coverage of the data that is captured within the NACRS. We right now have about 84% of the ED visits across the country each year, and you can see in terms of number of records, it's actually quite a bit. It's over 22 million records per year into the NACRS. So I want to spend a couple minutes talking about coverage because this is quite important, certainly from an analytical and use of data perspective. So I mentioned the DAD is the hospital data set, so essentially the acute inpatient data. Within the DAD, certainly the acute inpatient is the most comprehensive. We have all provinces and territories except Quebec in the DAD. Now, CIHI does collect Quebec data as well, Quebec hospitalization data from Medical, but that data collection is hosted in a separate data asset within CIHI called the Hospital Morbidity Database. And the Quebec data is currently not part of the Linkage to Statistics Canada's linked data sets. So right now, when we talk about the linked data set that are available through the RDC for the DAD, it's all provinces except Quebec. Day surgery is interesting because day surgery essentially is hosted in two different places. Currently with the DAD, as you can see in this table below, several provinces have started submitting day surgery data back many years ago to the DAD and continue to submit the data surgery data to the DAD. NACRS also includes some day surgery data, specifically from Ontario, Alberta, PEI, and Nova Scotia. So when we talk about day surgery analysis, typically we encourage people to really consider using both the DAD and NACRS. And we'll talk a little bit about the data elements captured. They're very similar in both. So it's quite feasible to look at day surgery analysis across the country by using DAD and NACRS data at the same time, but it's just physically they're hosted in two different data assets. Now, ED submission is actually the most interesting aspect here within NACRS. So a little bit of the history of NACRS. ED originally started, the ED data submission really started in Ontario and Alberta. And over the years, we definitely have the most comprehensive coverage of ED data from Ontario and Alberta. Over the years, many jurisdictions, as you can see, there is also starting to include their submission of ED data into NACRS. So over time, the coverage, as I mentioned, is growing at about 84%. It's really our goal to, at some point, hit really solid 100%, or if not 100%, close to 100% coverage for ED across the country. And you'll see actually here that we do have Quebec ED data sitting within NACRS. This is also a little bit of an intricacy or the nuance around working with NACRS ED data. So within the ED data set in NACRS, there's actually different levels of data submission. And this is, again, started out as a way to allow different jurisdictions to submit their ED data into CIHI in different ways. And these are all, options that different provinces and territories have adopted over time. So level one is essentially the most skeleton type of ED records. We have the wait times data elements completed in ED, but then in addition to that, and in level one, the hospitals essentially submit a presenting complaint or a discharge diagnosis pick list. So there's no hospital coding or abstracting resources, not heavily on the abstracting or coding resources involved in level one submission. And then all the way to the end is your level 3 submission, which is the most comprehensive and most detailed. This is where not only do you have all of the data elements, you have the presenting complaints and discharge diagnosis, but then we also have detailed diagnosis and intervention codes captured in ICD-10 and CCI within the level 3 AD records itself. So when we talk about ED analysis, it's actually something to consider in terms of the breadth versus the depth of information that you're looking for specifically for your research topic. And all of this information, I'll share with you afterwards, a couple resources that are available on our public website that you can go look into and review. Now, in terms of the types of data elements captured within DAD and NACRS, essentially they're very similar. And because the data assets are built, or data holdings are built in different time periods, the data element might be called slightly different names, but essentially it's capturing the same type of information within both data sets. So we would have kind of patient demographic information. So we do at CIHI receives, identifiers such as health card number and date of birth and gender and postal code. This information is provided to Statistics Canada, but I believe the data that's available for access within the RDCs would have been maybe de-identified or kind of encrypted in some way, right? But if you think about the source data that at CIHI we receive from the hospital, we do have these identifiers that would then allow us to derive geography information from postal code, socioeconomic factors, and other information such as that. And with Helcott number, of course, it allows us for linkages, patient-based or person-based linkage, both across time and also across data holdings. As well, we have a series of administrative data in both the data sets. And if you think about administrative data, is things such as, the date and time of admission, how long the patient stayed in the ED, how long they stayed in the hospital, how long did they stay in the SCU. So start and end times of various aspects of their stay within the hospital, within the ED. So a lot of that information is captured. Discharge decisions such as where the patient then went after they left the hospital or left the ED. So there's quite a bit of information about what happened to the patient during the hospitalization or during the ED visits. We also have service-specific information, so both from a patient service and provider service perspective, and this is just helping us or helping the use of the data to the user of the data to be able to tell what kind of services was utilized during that particular hospital stay or ED visits. And the most important piece, I think, and maybe of most interest to a lot of people using the data in ACRS is the diagnosis and the intervention information. So for instance, in the Discharge Abstract database, we do capture up to 25 diagnoses for every hospitalization. So you can imagine for a patient who has stayed in the hospital, we can look at what is the most responsible diagnosis, so the diagnosis that used up the most resources during that hospital visit. But there's also diagnosis captured both from pre-admit perspective and post-admit diagnosis. So there's different diagnosis typing that's being assigned to the different diagnosis codes that are captured within that particular hospitalization records. So from that perspective, there's a lot of opportunities to look at comorbidities, to look at conditions, and then the related utilization and the costs associated with that. And such. So it's actually quite rich in terms of looking at hospitalization and ED visits from that regard, looking at ICD-10 codes and CCI codes. Now, as you can imagine, for any of these data holdings, because they're long-standing, over time, we do see the need to either update or change the data collection methods, as well as some of the valid values that are captured for each of these data elements. So what I have included here is, and this information is readily available on our website. These are links to the CIHI website that has our metadata or documentation in place. So I think from an analytical perspective, there's two things that are most challenging when using these type of data assets, right? One is how certain data elements, the capturing of these data elements changes over time. So we do have a trending table in both pieces of documentation for data and ACRS to explain or to make explicit how in data element coding direction has changed from year to year. The other thing is also very often people would like to use the data and ACRS for pan-Canadian analysis or multi-jurisdictional analysis. So these data elements in the data and ACRS, while standardized, sometimes we do see some provinces wanting to have specific conditions or direction applied on top of CIHI's standard definitions and direction. So again, in these documentation, there will be some instruction about how the capture or collection of data elements may vary by jurisdiction over time. So again, really invite people who are interested in using these two data sets to refer to these documentation on our website. And I guess the other thing I wanted to maybe just talk a little bit is at times we do get some questions about, well, how do we know if the data within the DAD or NACRS is accurate? Like what kind of steps does CIHI employ to make sure that the data really reflects what happened in the hospital visit? So I would say that there's a couple components to it. So first off, it's for both the DAD and NACRS, we do have a very comprehensive abstracting manual that is published. And that abstracting manual is available to all of our data, all of the submitting hospitals and organizations. And in there is very detailed instruction and collection guidelines about how each of the data elements should be defined, what are the valid values, and really some case examples for our coders and abstractors within the hospital to use so that they can capture the information as consistent to how we direct them as possible. So that's part of the instruction to our coders and to our abstractors. Then once the data is submitted to CIHI, we do run all of the data submission through a pretty extensive validation and added rule process. So we have an engine where the data is passed through very, quite a series of edit checks. So for example, checking for logic across data elements, checking for validity of data elements and the format of the data elements. And if we do identify, if the system does identify errors or what seems to be error in the data submission, we have an error correction mechanism. So the data set is then sent back to the hospital, they correct it and resubmit again, and we run through the process until we get a clean file. So to the extent that we can, I think we've placed a mechanism to make sure that the hospitals have the standard guidelines and collection rules that they can follow. And then we put in place edit and validation to make sure the data is according to standards as much as possible. Now, in addition to that, here on screen, you'll also see CIHI does have an information quality framework where, annually for every data set, we look into these 5 categories of information quality and looking at and assessing our data sets essentially against these criteria around relevance, around timeliness, and around accuracy. So there's certainly some mechanism in place at CIHI to make sure not just the data inaccuracy, but all of our data assets meet certain requirements. And here I'm starting to maybe switch gear a little bit and just listed a couple of the linked data sets that we know are available through the RDC, and these are the linkages that has been done to different Statistics Canada's data assets. And I know, Aaron, you'll be speak to a couple of these, but generally to say that there is quite extensive kind of linkages that's been performed between the DAT and the NACRS to several survey data and longitudinal data sets within Statistics Canada. And I know, like, just basically, I'm just looking at some of the previous linkage exercises and projects in the past, and these are some of the things that you can broadly imagine using the hospitalization data in conjunction with Statistics Canada data assets. So looking at hospitalization, typically the strength of CIHI data is looking at hospital utilization, looking at health outcomes, and then by linking to social data or immigrant data or survey data, you can imagine being able to broaden those analysis and those conclusions in a variety of ways. So maybe with that, I'll transition over to Erin and see if you want to take this over and share a little bit of your experience. I'll stop sharing.
Thanks so much, Juliana. That was great. And I will share my screen. I hope everyone can see that. So so I'm Erin Hetherington. I'm actually talking to you today from Montreal, which is the traditional territories of many First Nations, including the Kanawake, and has been long served as a meeting place of exchange of ideas amongst many First Nation groups. I actually just began a job as an epidemiologist at the Public Health Agency of Canada, but I am not representing that agency here today. I'm going to talk to you about my experiences using linked data sets in the research data centers, both during my doctoral research at the University of Calgary and my postdoc work at McGill. So I'm particularly interested, and I'm not able to advance my slides, so that's confusing for me. Oh, here we go. I'm particularly interested in perinatal health and perinatal health inequities. And so if we think about where the state of that research is today, a lot of the information that we have about these issues come from international data. So the US birth certificate data is a great source of publicly available data. They collect information on birth outcomes across the country. You can have maternal race ethnicity data, maternal country of origin, education, even some behavioral variables around smoking. And so this has been used to look at, for example, issues of preterm birth and why preterm birth might be particularly a lot higher amongst the Black population in the United States than it is compared to the white population. The Scandinavian countries actually do a great job with birth data as well. They have these birth registries where they collect the information on all the births, and then they're linked to census variables. And so there's lots of interesting information coming out of here in terms of perinatal health as well. And one particular area of interest for me is looking at cesarean sections. The Scandinavian countries have traditionally lower cesarean section rates than most other industrialized countries. And so when you're thinking about what goes into that, how immigration may impact cesarean section rate and preference, that's a great source of information. In Canada, though, the Canadian context is a little bit different, and until recently, a lot of this research has to be done using either administrative data sets or hospital-based cohorts. Administrative data sets, as Juliana has just talked to us about, have a real wealth of information in terms of that health outcome data. You can do, there's a lot of richness there. They tend not to collect very much socio-demographic information. You get age, you get sex, and you may get some kind of postal code information, maybe the first 3 digits of a postal code that you could link to some area level markers, but not individual levels of income or education or race or country of origin, for example. Hospital-based cohorts are great. They're purpose designed. You can ask all the questions you want, but they're really expensive. They tend to not get updated. They're, they go stale very quickly. And so this has been a challenge in Canada to kind of look at some of these questions. Now, the data landscape is changing, and there are lots of efforts, especially at the provincial level, to do a lot of these data linkages. So Ontario stands out with the with ICIS as having a lot of data linkages amongst different data sets that allows you to explore some of these things. But Manitoba as well has great data linkages, BC, Alberta, there are probably more that I don't even know about. The problem is looking at it in a pan-Canadian context. You usually cannot get individual level data to pool across different provinces, and that's where the research data centers and these StatsCan data linkages come in and really are providing a way to address that gap. So I'm going to talk to you about the 2 projects that I have worked on in the research data centers and some of the challenges and things that I've encountered in working with this data. So the first was using the Canadian Community Health Survey, which many of you may be familiar with, has lots of socio-demographic data, but also very rich behavioral questions. It's administered every couple of years, and that's been linked to the hospitalization records. So I looked at cesarean deliveries amongst Canadian-born and immigrant women in that data set. And then I have an ongoing analysis using the Canadian health and environment cohorts, the CanCheck data, also linked to hospitalization records. And that's looking at racial inequalities in birth outcomes amongst immigrant women to Canada. So I want you to think about, like, as we go through this, what kind of things that I wish I had known as I was designing these projects, and what might help people as they think about what kinds of research questions are answerable and are feasible in these types of data sets. So you do need to think about what variables are available and what they cover. And so, for example, the hospitalization records, as we heard, rich source of data. However, for reasons outside of our control, Quebec does not share that data with Statistics Canada. And so if you're looking at any kind of interprovincial comparison, or you're interested in a particular policy question regarding Quebec, that's not an appropriate data set to use because you simply don't have data on that entire province. Vital Statistics tends to be national, but it's not as rich. It doesn't collect as many variables. And so while you have birth certificate data or death certificate data, you don't always have all the variables that you were looking for. On the other side, the socioeconomic data, depending on which data source you link to, you have different things depending on which data source is linked. So you do have education, labor and income, race and ethnicity questions, immigration questions. And then if you're using something like the Canadian Community Health Survey, you have lots of behavioral questions, but some of the other data sets don't have these things. And it's tempting, because these data sets are so large, it's tempting to think, oh, I'm going to have the sample size to do whatever I want, ask whatever question I want. And one of the things that I encountered when I was looking at cesarean sections amongst recent immigrant women, I used 11 waves of community health survey data. I pooled all of those together. And then I used 15 years of hospitalization data and pooled all of that together. And so that gave me over 100,000 deliveries. And I was like, that's great. That's a huge sample size. But then when I actually narrowed it down to women who had immigrated to Canada in 5 years, within 5 years of giving birth in Canada, so recent immigrants giving birth in Canada, I had fewer than 2,000 women. And then within those 2,000 women, only 30% of them had cesarean section rates, right? So all of a sudden your sample size really can collapse depending on what particular group you're interested in, how that group is captured and represented in the data. I think the other thing to think about is really when your data are collected. And this is, I can't stress this one enough. So your outcome data, again, as Juliana mentioned, you have granular date level data, sometimes hour level data about when certain things happened, which is great. And usually our outcomes are health related, so that's pretty good. However, there are changes in these data sets over time. So if you are pooling data across many years, you may encounter things in the structure of the data that make it difficult to answer the question with regards to a time trend. So for example, in 2000, most hospitals were using an ICD-9 coding system. And over the 5 years from 2000 to 2005, they switched over at different rates in different provinces to an ICD-10 coding system. So you can parse this out and you can use algorithms to correctly code whichever province had which coding system, but the coding systems don't exactly line up. And if you find a change in the trend over time, you have to make sure to ask yourself the question, is that really a change in the actual outcome, or is that due to a coding change or some other structure of the data change? So you do need to think about that. On the exposure side, these are very likely to be time sensitive. So things like age we can keep up with. Usually biological sex is something that's not very variant over time, so that's fine. Your racial identity may or may not vary. It's usually considered to be fairly stable, but some people may choose to change their sort of racial identity over time. But if you think of things like education and income, these really are quite time sensitive. So for example, I'm using a data set which uses 2006 census data. And then I'm looking at hospital-based deliveries from 2005 to 2019. So there are people in my data set who were 15 or 16 years old at the time of the census, which is when their education and income data were collected, but they didn't give birth until 10 years later. And so that education and that income variable is not really relevant anymore. And so yes, there are these huge sample sizes, but how valid it went as you get further away from when these things were measured, how valid does that data remain? So you do need to think about those things as you design your project. The next, the next piece to think about is just these data sets are really large, right? So you do need to trim before you start. You usually get the data set in lots of different pieces, right? So you'll get the DAD data and you'll get 12 files corresponding to 12 different years of DAD data. You have to collapse them, put them all together, trim them all up to find your cases. Same thing with the census data or the community health survey data. You have to clean this all up even before you merge the files together because they're so big. Having as much pre-prepared code and algorithm as possible is really important. Troubleshooting, especially we use a lot of algorithms for case definitions for using ICD-10 coding and that kind of stuff. Troubleshoot those before you go into the data center. It's very difficult to do once you're in the data center just because of the privacy and security restrictions in that environment. So having as much of that pre-prepared and validated ahead of time is a good idea. And then the other piece is that data linkages are not perfect, right? So as much as folks at CIHI and at Stats can do an amazing job at data quality, you are not immune from doing your own data quality checks. So I'm going to give you a couple of very specific examples. I deal with pregnancy. So often we have multiple deliveries assigned to the same person in the data set. Now I had an instance where I had 3 deliveries assigned to one individual, and that individual's birth year was 1975 in 2 of the deliveries and was 1955 in another delivery, right? So obviously that was just an error, but I needed to catch that because then all of a sudden that person's age at delivery kind of changed in a sort of very bizarre way. The other piece that I have encountered is deliveries being associated with a 3-year-old girl or a 75-year-old woman. So obviously these are probably data linkage errors. That's biologically very improbable that that is actually a true case, but you have to do your homework. You have to check these things. So just kind of a few things to think about as I wrap up. I was asked to think about what would make these data even better. And there's a temptation to be just say more linkages. We want more. And that's great. More is better. I would say more current is probably more urgent. So I'm currently working with 2006 data linked to CanCheck. That is, there is 2011 data, but the 2011 National Household Survey had some issues with it. And so that census data is getting a little old. And I know the 2016 census linkage is coming up, but as soon as that could be available, that would be great. I think more information for users on that probability of correct linkage. So in Stats Canada, there's lots of work within the secure data learning environment to do these linkages. There is a variable about how confident they are about those linkages, but that's not available to users. And so when you come up with these strange cases, it would be nice to know how confident the folks doing the linkage were about these particular cases. I think ease of use is another real key piece here. As I said, these data sets are very, very large. You do usually get them in multiple different pieces and you have to link them across these different sets. Often you have to use multiple variables to link them. Having just a unique variable to link everyone across the data sets would be great. Standardized naming protocols would be great as well. Some statistics programs don't care if you capitalize or not, other ones do. And so if it's kind of random between the data sets, it's just a little messy to do. And because you have to trim before you link, it's not always obvious if you've done the linkage correctly. So having sort of easier linkage operations would be great. But I think most importantly is just a little bit more guidance and support for users on how to use the weights. So I understand how Stats Canada has developed weights so that they are nationally representative based on their sampling design, based on linkage rates, these kinds of things. And that makes sense in a snapshot context. I think we really understand how that applies to a group of people at one time. But as these data linkages evolve, we often have a case of repeated measures over time. We're often using more complex modeling strategy where you might have longitudinal outcomes that you're looking at. And it's not really always clear how to use these weights, whether the weights are appropriate, how to model them if you've got repeated measures. And so a few more, I think more kind of guidance or user-friendly documentation on how to use those weights, especially in a repeated measures context, would be useful. So I'm going to wrap up there. I know we're going to open this to everyone for questions, but it's been great to share my perspectives so far.
All right, excellent. Thank you, Juliana and Aaron. Those were really interesting presentations, both from starting off with a good understanding of what data is available, but then really getting into some of the practical issues around using the data. And if for folks who attended the previous session, all right, there were some comments about how we don't get courses on data manipulation. And I think Aaron pointed out some of the issues around that. So one of the things I was thinking, I'm not sure how used or how often sort of folks use some of these linked data sets, but one of the things that came to me was, I guess, as more researchers are using this data, hopefully that will encourage more people to use it, and then we can kind of learn from each other and make it easier for us to learn from each other and share code, etc. So I just have, there are some questions in the chat. As moderator, I'm going to take the prerogative of asking the first question, which I think is actually linked to a couple of the questions in the chat. They're probably going to answer it through that. So that's around, so I know sort of for the data is collected through the hospitals, and with respect to timeliness, right? I know if it used to be released sort of once a year, because it takes a while to clean it up, and there's obviously a lot of work involved in that. At the beginning of COVID, there were a lot of questions around hospital admissions. So I know we were at one point getting monthly updates and then quarterly updates, but still there were like lots of lags in that data. They weren't as good as the fiscal year data. So I'm just wondering about sort of going forward, are there any conversations about either making changes to the DAD, or alternatively, I know there, and at CIHI, you guys have had some discussions about some alternative potential data sources that will collect some of this data. And so what I'm really thinking is, you know, we're referring to this as administrative data. I would kind of argue in some ways it's now even surveillance data, right? Because we need to understand, you know, how many hospital beds do we have as we're trying to make public health decisions, et cetera, and what's capacity and utilization, et cetera. And I know CIHI has been working with the provinces to collect some of the data, but basically, can you speak to any initiatives of sort of moving forward of where you might be going in with respect to that type of work?
Yeah, I'm happy to answer that from CIHI's perspective. So certainly, we're now calling the open year data or provisional data. So it used to be the traditional model where we close a database at the end of the year. So the fiscal year ends March, and then we have the final data sets or final submission deadline from the hospital in June, and then we create an annual data file. Especially since COVID, we're now moving into more of a provisional data setup where really as the data come in, we're fit for purpose. We can use that data for data requests from researchers, and we can also use it for media requests and also for CIHI's products and services. So on our CIHI website, you would now see quick stats or statistics that are available within, say, 3 to 6 months of the discharge, and that's essentially in-year data, right? Now, having said that, I think what's going to be available within the RDC would be different because our data sharing or our data flow with Statistics Canada at this point is still on an annual basis. And then once the data get to StatsCan, it has to be linked, right? So the linkage process is within Statistics Canada. So I wouldn't be able to speak to the timing from a Statistics Canada perspective. But I think certainly we can talk about at least from a CIHI to StatsCan flow, whether that flow could be done more frequently, so that if the capacity is available within StatsCan to do the linkage more frequently as well. But you know, there's a couple of a stepwise process to get that happening. Nope, you're on mute.
All right, so I'm going to go down the list. Actually, there's a whole bunch of questions now that have just popped up. So the first one is, I wonder if there's a data team, data engineers and data analysts in every hospital dealing with creating and maintaining the database to be ready for being imported to StatsCan. But before you answer, I'll just note that, you know, working in the last couple of years, we've had meetings with consultants who come to us looking for data or researchers at times. And the assumption has been by many people across the country that there are teams like that, and that, you know, at any instant, you know, we can answer the question. CIHI gets data sort of, you know, every 24 hours with respect to how many people are in hospitals and stuff. So I think I know the answer, but I'll let Juliana speak to it.
Sure. So a couple of clarification. One is the data doesn't flow directly from the hospital to Statistics Canada. The data flows from hospitals to CIHI and then to Statistics Canada. Now within a hospital, I think typically, really, if you think about hospitalization record, there's different sources within the hospital that contribute to the data within the record. So there's certain information that can be captured through an ADT system. So it's pretty automated. ADT stands for admission, discharge, and transfer system within the hospital. So typically those are like your dates and times and standard information, you know, demographic information about the patient. And those type of information almost is quite timely. It's real time. It can be captured quite real time, right? Because it's in the ADT system within the hospital itself. What gets more time consuming from a coding perspective within the hospital is the whole abstraction step. And by abstraction, we mean is if you imagine you're a patient in a hospital, you have a patient chart. And within the chart, your doctors and nurses write all their clinical notes that are not in codes, right? And then in each hospital, there are people who are then taking these notes and translate it or transcoding it into ICD-10-CA codes or CCI codes that can get loaded into the records. That's a step that's very human resource intensive because it does take expertise for people to do that coding exercise, right? So typically, I wouldn't say it's data analysts, a team of data analysts, but I would say it's a combination of ADT system feeds plus coders actually doing the work to capture the information. Hence, we're not quite there in terms of knowing in real time how many people's in the hospital and being able to see that within a DAT, because the DAT does take that time for abstracting and coding to happen. Having said that, I think we're now seeing that within 3 months, typically of a discharge, the record is within our data assets, right? And for ED, it's actually a lot timelier than 3 months. So we are seeing progress, but it is a undertaking in terms of getting the information into the data sets.
Okay, great, thanks. So next question has to do with, will CIHI consider collecting or abstracting data on BMI and smoking status? And I don't know if Aaron might be able to answer that better given the linkages, because I would think that within the CCHS, you'd have some of that information that you could then link to the CIHI administrative data, but whoever wants to take it.
You can start with the CIHI perspective, because I think the CIHI, like, it's a lot of what gets decided and what goes into a data analysis is really dependent on the feasibility of that information being available within the hospital, right? So if you imagine like smoking status, that may not be something that's captured in a hospital stay. And that's why, you know, adding or deleting a data element in the data analysis is a conversation with our data providers to say, is this feasible? Is this information within your system? How resource intensive to get at that information? So it's a balancing of those things. But Aaron, maybe your thoughts on those type of fields. Yeah.
Yeah. Again, I think those linkages provide an opportunity to tie some of those behavioral questions to the health outcome data. But again, it's a question of timing, right? So if you have measured someone's smoking status in 2005, is it still, how long have they been smoking? Sometimes the data sets ask sort of the length of time, but sometimes they don't. And so it is a difficulty when you're trying to then abstract it to years later, is that, you know, exposure still valid? We do sometimes have algorithms to try and identify, for example, alcoholism or tobacco use or substance use, for example, in the pregnancy data, but they tend to be very low quality and they're not really very good. So you can sometimes capture that information, but it's better if it's linked to current behavioral questions.
Great, thank you. Next question, actually, I jotted down the same question. So it's about any plans to link any of this hospital or CCHS data to primary care or physician data. Like, ideally, there's a lot of questions about pathways of care, readmissions, etc. So any plans on that in the future?
I think at least at CIHI, it's early days in terms of building our capacity to collect primary healthcare data. We have started piloting in different regions within Canada, but I think we're still early stages. Right now, we're looking at content standards and exchange standards for PHC data collection and submission. But I know at CIHI, at least, it's not an imminent thing that would happen for months. So.
All right, excellent, thank you. So there's several more questions here, so I know we're just about out of time, and I know the next session starts in a few minutes. So perhaps, folks, Juliana or Aaron maybe can get back to some people. I think, well, and just one last question I will ask, and this has come up and is related, is with respect to the timing or what the most recent updates were. So I think somebody noted that the linkage is up to 2013, and there was a question of whether or not there are plans to be updating those in the near future.
So I think the different data sets have different linking times, right? So I know that the CanCheck is linked to 2011, is linked to DAD records up to 2019, but some of the other ones are a little bit more recent than that. So I do think it's data set specific, and I don't know anything more about the timing of when those might be updated.
All right, okay, great, thanks. So yep, it is 2 p.m. So lots of questions as well about documentation, etc. So folks are obviously quite interested in this. So hopefully we can follow up offline and keep this conversation going. So I thank everybody for joining us, and I'll turn it back over to Grant, or are we just closing the session? Or
well, I had said we were going to go right to break, which we can do, but I will thank again Aaron, Juliana, and Alan for a great session. There are so many questions here. I am going to try to answer via chat, what I can, what I know. And Juliana, if I can beg of you a few minutes of your time, you also have access to that panel, and if there's answers you want to type in, that would be fantastic too. Sure. Thank you so much, and we'll see everyone at 2:05 for the International Armchair session.